Hello everyone, welcome to the KCIAPM Path webinar session. Today's session will be on GI Path topic. But before we begin, we have a very sad announcement to make. Dr. Prasanna Shetty left us recently, and Dr. Shetty served in various capacities for 32 years at MS Ramaiah Medical College, and recently had retired as professor and head at Department of Pathology at MS Ramaiah Medical College. He was a very pleasing personality, and if you meet him once, you would be totally blown over. And he was a very passionate teacher and a pathologist par excellence. He served KCIAPM as its treasurer from between 2006 to 2012 and was very entrepreneurial. And we pray to the God to give his family strength and courage to deal with his loss, and we sincerely condone his death. To pray for the departed soul, let us observe a minute's silence before we begin today's session. All right, thank you all. And I'm sure if you knew Dr. Prasanna Shetty, you would have a lot of good things to say about him. Please share your views in the comment section, and let's begin today's topic. And to do that, I hand over the session to Dr. Basavraj Yamkan Maradi, our member of a social media subcommittee, who will moderate today's session. Thank you all.
Hello, good evening everyone. I welcome you all to the KCIAPM Path web series for the month of June. Just a few housekeeping notes before we begin the session. All of you please set the YouTube resolution at 720p and and actively participate by posting your questions at chat session. We will take all the questions at the end of the session, and please don't forget to subscribe to the KCIAPM social media channel. So I welcome Dr. Siddharta Datta Gupta. He is a stalwart in the field of GI pathology and hepatobiliary pathology. So Dr. Datta Gupta, he did his MBBS from the St. John's Medical College and MD in pathology from the AIMS Delhi. So after that, he served a couple of years as a faculty at St. John's Medical College, and then returned back to AIMS Delhi, where he served his entire career and retired as a dean and professor of pathology. So during his tenure, he did a one-year course in GI pathology and hepatobiliary pathology from the UK. Dr. Datta Gupta is currently back to hometown and serving as an adjunct professor at the St. John's Medical College, Bengaluru. He is a member of various subcommittees for the GI pathology with many publications to his credit, and he is a most sought after a resource person for the GI pathology session. So ladies and gentlemen, now I will hand over the session to Dr. Siddharta Datta Gupta, who will be speaking on the basics of inflammatory bowel disease on endoscopic biopsies. So I will hand over to you, sir. Sir, yeah.
Thank you very much.
The session to you, sir.
Thank you so much for your kind introduction. Actually, I'm a student of BMC, not at St. John's. Later, I joined St. John's. Anyway, So I'll share my screen and then let's begin with this.
Yes, it's visible.
Yes. Right, I can start now.
Yes.
Well, today's topic is just the basics of IBD or inflammatory bowel disease, the main histological features on endoscopic biopsies. We'll not go into too much details, and hopefully this will help the postgraduates in understanding this condition. Well, inflammatory bowel disease is actually chronic inflammatory intestinal conditions, which is mainly idiopathic. And there are two main categories: ulcerative colitis and Crohn's disease. Many people try to include the other ones like microscopic, lymphocytic, collagenous. Some say they are precursors and so on. But as far as worldwide, what is considered is that these two diseases, ulcerative colitis and Crohn's disease, are the two diseases that are included under inflammatory bowel disease. Well, the annual incidence and prevalence of the inflammatory bowel disease is varied. It's supposed to be more in the Western world in comparison to Asian countries. But it's known that nowadays, it's known that Asians who have migrated to the Western world, they have a higher incidence of inflammatory bowel disease than those who are at home. So there may be other factors, but all the same, it's the incidence and prevalence are increasing over the years, and although we do not know the exact incidence and prevalence in our country, and there are regional differences. Most studies from the northern part of our country have shown that it's around 40 per 100,000 population, which is pretty high, it's not very low. And in a national survey done in 2012 by by a task force of gastroenterologists and others in our country, and the ulcerative colitis was found to be almost equally prevalent in both north and south. So you must be seeing a lot of cases here. And Crohn's disease is generally higher in the southern part of our country than in the northern states. So with this in background, we go further. You see, we are going, the mainstay of diagnosis of inflammatory bowel disease is because of their symptoms are mainly diarrhea, colicky pain. Sometimes they have bleeding per rectum and so on and so forth. So the mainstay of diagnosis is based on colonoscopy and biopsy. But nevertheless, this condition can affect even the small intestine, and the Crohn's can affect the stomach and duodenum in about 5 or 10% of cases. So almost the entire GI tract can be affected. They also have extraintestinal manifestation, which may tell the gastroenterologist or point the finger from a physician that this may be related to ulcerative colitis and so on and so forth. Of the extraintestinal manifestations, I must make it clear right here that primary sclerosing cholangitis, which is seen in the West associated with ulcerative colitis, is very rare in our country. But you can get arthritis, uveitis, and other features. So if you are doing a colonoscopy, you'll find that the colon looks different. Inside of the colon looks different in different portions. You start from the terminal ileum, you enter the cecum, and then the opening of the appendix, and then you go toward the ascending colon, and then the hepatic flexure, go to the transverse colon, which has this typical triangular appearance because you have the three linear linearly arranged in a well-oriented fashion. And then you have the splenic flexure. You go down through the descending colon, then through the sigmoid, and then to rectum and anal canal. So this is how it will look from terminal ileum. We are entering. This will be the ileocecal valve, cecum, appendix, ascending colon. The two flexures, the transverse colon, descending sigmoid, rectum, and anus. Now, if macroscopically the appearance is so different, so microscopically is it the same or not? So naturally, one has to know what the normal appearance of the colon is, colonic mucosa is, because we are dealing today with mucosal biopsies. The you have a crypt, and then you have the intercryptal table, that is the surface epithelium, and you have both columnar cells and goblet cells, and you have inflammatory cells, mainly lymphocytes, which are a mixture of uh, T lymphocytes mainly, and they are less than 20 on the surface per 100 epithelial cells. If it is more than that, you can make a diagnosis of lymphocytic colitis, provided there's other symptoms in otherwise endoscopically normal mucosal biopsies. There are about 75 to 115 cells in each crypt, and they keep getting renewed. And the cells, the dividing cells are somewhere at the base of the crypt, and they gradually migrate to the surface on top. Panet cells, if at all they are found, they are mainly found at the base of the crypts. They do not migrate. We have mucous secreting goblet cells also, and the remaining are absorptive cells. The crypts will not only grow in number of cells, they also divide. And the division starts from the base and then goes to the top. So when crypts are dividing into two, you will find first two crypts forming at the base and then going across right to the top. So they will look almost like trousers in the beginning when they are dividing. These are known as branched crypts. We'll come to that later. The crypts are arranged in the mucosa in the form of almost test tubes in a rack. They are very systematically arranged. This will be the crypts, this will be the intercryptal area, again another crypt, and so on and so forth. This is how they look like. And if you are seeing, this is the crypt in the rectum, and this is the crypt in the ileocecal region. If you see, there is variation. This is right at the near the anal canal. You will find that the goblet cells are increasing as it goes towards the rectum. The inflammatory cells are different, and the eosinophils, number of eosinophils are also different in different regions of the crypt. The lymphoid follicles also, which you may find in the crypts, are also different. So there are variations in the mucosal biopsy. If you take from the cecum to the ascending colon to the transverse colon, and then way down along the descending and sigmoid colon. You should be aware of these differences before you can make a proper interpretation. What are these differences? Firstly, the absorptive cells are more often found in the right side of the colon. We generally divide right side of the colon as up to the splenic flexure, you can say, and goblet cells are relatively more in the left side of the colon. In fact, the gradient is 5:1 to 3:1 because the goblet cells are more in the rectum. Secondly, the intraepithelial lymphocytes are more in the right colon, while goblet cells are relatively more in the left, which I told you. So the IELs are more in the right side of the colon. Then Paneth cells are derived from the midgut. The midgut ends near the splenic flexure at the junction of the right 2/3, and the left 1/3 of the transverse colon. That is the watershed area, which is supplied by the middle colic and then sorry, by you can get by the mesenteric arteries, superior mesenteric, and beyond that by the inferior mesenteric artery. Right. So the midgut starts from the ampulla vata right down. It goes to the junction of right 2/3 and left 1/3 of the transverse colon. So Paneth cells are found in mainly in the midgut. So you will find them mainly in the small intestine and a little bit in the colon, which is on the right side, which is derived from the midgut portion. And beyond half of the left half of the transverse colon, you rarely find Paneth cells, and they are not to be found thereafter after the splenic flexure. So therefore, finding 1 or 2 Paneth cells on the right side is perfectly normal. On the other hand, if you find it in the left side, it is abnormal. So it's very important to note these differences. The inflammatory cells in the lamina propria are more on the right side of the colon than on the left side. And the same applies to the lymphoid aggregates, which are more on the right side of the colon than on the left side of the colon. Eosinophils are present mainly in the right side of the colon. There are few of them are found in the left side also, but the highest number are in the cecum. Therefore, if you take a biopsy from the cecum and you see a lot of eosinophils, it may be a normal variation. On the other hand, if you find an equal number there on the left side of the colon, then it is abnormal. So on the left side of the colon, you find more of goblet cells. The IELs, Paneth cells, inflammatory cells, as well as lymphoid or aggregates are more on the right side of the colon. Similarly, eosinophils are more on the right, but highly concentrated in the cecum. So this basic normal variation you should know. The next is these colonic crypts are like test tubes which lie on the muscularis mucosa. If you see this, when it is elongated, told you there are about nearly 112 cells like this here. So when it is elongated, then you call it hyperplastic or hyperplasia of the crypts, right? Hyperplasia or elongation of the crypts, the term is used. And it's obvious, you have to keep seeing colonic biopsies. You don't have to measure them with a micrometer or anything to say, to find out elongation of the crypts. Second is branching of crypts. Branching of crypts are seen in dividing colon. So therefore, they are not found in adults generally. Finding 2 branch crypts in a biopsy along with inflammation. Please remember both of the things are there. That becomes a significant crypt architectural abnormality. But below 9 years of age, below 10 in the pediatric age group, you may find crypt branching more than what I told the previous 2 branch crypts. You may find 3 or 4. It doesn't indicate that there's an architectural abnormality in children. And if you find a crypt that is above lymphoid follicle or anything which is branched, you can ignore them, right? Then the other thing which you must be aware of is what are called innominate grooves. These are small grooves in the colon, in the mucosa, and they are called innominate grooves. Along the groove, the crypts actually radiate from the grooves. The importance of knowing this is that suppose a section is cut from here, right? Like this. This is the part of innominate groove. and a section is cut like this. So you may mistake this for a branched crypt, right? So you have to be careful when you're seeing, you have to take deeper sections. And the other finding that will be help you is you'll find branching more than 2, 3 or 4. Then you can safely say most probably this is an innominate groove and not crypt branch. Then Paneth cells. Paneth cells, I told you, are mainly found in the right side of the colon. Don't get in the left. They are actually large cells with nucleus at the base and granular cytoplasm, almost like an eosinophil. So this would qualify for a Paneth cell metaplasia, especially found in the left side. And just see, these are plasma cells. Generally, you don't find plasma cells in the base of the crypts as you're seeing here. So this would qualify for basal plasmacytosis, lot of plasma cells. This is seen typically in inflammatory bowel disease. Within a week or so, you can get this basal plasmacytosis. And here these are Paneth cells. Now Paneth cells can be mistaken for another cells, that is the enterochromaffin or enteroendocrine cells. Now they are different from Paneth cells, but they also have red granules, but the granules are much finer. These cells are more or less triangular in shape, they are much smaller. The other thing is that the nucleus of these cells are towards the lumen, whereas if you see in the Paneth cells, these will be found more towards the basement lumen. So this is one point you should be very careful. And when you see a cell like this, you feel this must be the nucleus, or maybe this. This is actually, you see the nucleus is crowded here. So you have to take more deeper sections, and there's likely to be Paneth cell because you see the granules are quite coarse, unlike that. Okay, so this is because of sectional artifact. You have to find a single layer of cells, then you can judge these small nuances better, right? So this is how you, if you do, of course, if you're having the facilities, you're rich enough to have these, you can do any of these chromogranin or synaptophysin stain to prove that these are endocrine cells. Now the inflammatory cells normally are found more on the superficial part than in the basal part of the mucosa. So deeper portion of the mucosa has less inflammatory cells normally, lymphocytes, macrophages, etc., than the uh, portion of the mucosa which is near the muscularis mucosa, right? So this is very important. In IBD, it's all, you get a lot of inflammatory cells in the base. In infective colitis, the inflammation is mainly in the upper third or up to the middle third or middle half of the mucosa. They generally don't extend that much into the lower portion, at least in the early stages, because clinically an inflammatory diarrhea or due to an infection or due to IBD may appear similar. Okay, so this is another thing. Then lymphoid follicles, they are normally present in the colon, but if there are more than 4 in a low power field or more than 2 per millimeter of the mucosa length, then they are abnormal. Lot of lymphoid follicles are found in divergent colitis. They're found in inflammatory bowel disease also. Okay. Then neutrophils are never found in the mucosa lamella. 20 inflammatory cells normally, that is lymphocytes and macrophages, which are normally resident in the mucosa, you will not find a single neutrophil. if there is 1 to 5 or 20 inflammatory cells, then the neutrophilic infiltration is mild. If it is more than 5 per 20 inflammatory cells, then it is marked. In active colitis, due to any cause, whether it is infection or due to the inflammatory bowel disease, when it's active, because it has periods of waxing and waning. So active colitis will go to activity in IBD. So then you get a lot of neutrophils. The neutrophils may lie in the lamina propria, or they may infiltrate the crypts, or they may be found as an aggregate inside a crypt. So if they are found in the lining epithelium of the crypt only, they neutrophilic infiltration in the lamina propria are all features of active colitis. It can be seen in infective colitis, it can be seen in IBD. But in infective colitis, feature that can tell you whether it's infective or not. Same thing, crypt abscesses. Also, you'll find this ball of neutrophils mainly in the upper portions than in the lower portions, right? So these are not definite, but these will point the diagnosis from one to the other. Plasma cells and lymphocytes are common, but generally, if you find them in fairly large numbers towards the base, then it indicates that it's most likely to be IBD. Macrophages are common. They are found everywhere in the colon, most often in the rectum than elsewhere. And if you are taking, say, purgatives or other things, you may get this pigmented macrophages in the rectum. Nothing to worry about that. Okay. So I talked about the normal variation. You must be well versed with this, with all the where the absorptive cells are moving, because you use the term goblet cell depletion. It depends whether how many goblet cells have depleted, and unless you know the normal, you may misdiagnose or overread the changes. IELs and Paneth cells, inflammatory cells, more common in the right than left side, lymphoid aggregates, same thing. And if you find more than 4 in a low power field or more than 2 per millimeter, then it's abnormal. And eosinophils, I told you, they're more often seen in the right colon, highest number in the cecum. We also use the term focal or patchy chronic inflammation. Now, if the background cellularity is normal and there is localized increase in the number of inflammatory cells, then you call focal increase. If the background is more and the intensity, you get small aggregates in that increased background cellularity, people say it's patchy increase. This is different from what you say patchy inflammation of the colon. This is patchy chronic inflammation in a biopsy or a focal chronic inflammation in a biopsy. When they say that the colon is affected in a patchy manner, it means it's almost like a segment of the colon. One portion is affected, then another portion may not be affected, another portion is affected, and so on and so forth. So this term sometimes may mean different things when used in different connotation. So this is focal inflammation. Background inflammation is just about normal, and here there is focal increase. So this is focal inflammation seen in an endoscopic biopsy. There the background inflammation is obviously more, and here it is increased even more. So this would qualify for a patchy inflammation in this biopsy. The other thing you must recognize before interpretation is changes due to bowel preparation and artifacts, because the colon has to be clean before you do a colonoscopy. And to keep it clean, what they do is they usually earlier they used to give enemas and other things. Nowadays they give an osmotic agent like mannitol or pegylated substances, so that when you drink it, it pulls all the water, cleans the colon. And so there should not be stool and other material clinging on to the mucosal surface. It should be absolutely clean. So lot of things are given. So now when that is called preparation of the bowel. So what happens is sometimes the absorptive colonocytes become cuboidal in shape. The goblet cells, they may be irritated, so they discharge all their mucus. So there may be a reduction in goblet cells. The surface epithelium sometimes become detached, and there may be focal surface epithelial neutrophilic infiltrate, extravasation of red blood cells, and some increase in apoptosis of crypt and surface epithelial cells. So these you'll see only through experience. For example, if there is graft versus host disease, they often do colonic biopsies, and then you may find a lot of apoptosis, which is a hallmark of this graft versus host disease. So while you keep seeing slides, you'll have an idea. So earlier oral sodium phosphate was given, which showed exaggeration of several of these features. So nowadays polyethylene glycol is given, which shows very little histological alterations. Although there may be some superficial mucus loss and inflammatory infiltration, but rarely you'll find erosions and other things. The other thing is that the biopsy forceps should not be should be, it actually pinches and then squeezes it out. So you should be fairly gentle. So when you're a little rough with it, you may get this focal hemorrhages. So you need not worry about these small things, that there's some problem here. So you'll be used to this. See here, there's another one. This is a lymphoid follicle here, and another aggregate possibly of macrophages there, right? Then you may find some of these changes with these cells don't look well. Okay, so these are the other things. These changes are mainly because of artifacts of fixation. Sometimes they keep the colonic biopsy in the refrigerator, and then you get ice crystals, and you see because when ice crystals form, they expand. 10 volumes of water become 11 volumes of ice. That's well known uh, physics. And then so when you again thaw it, so you get these large spaces. And if formalin is not proper also, you can get some of these changes. Now, these are pseudolipomatosis, but these are nothing but spaces, often because when they do colonoscopy, they insufflate with air. So some of it is believed to be because of air insufflation. Many times we do not know the reason. This is called pseudolipomatosis, which is another thing. They look almost like dilated lymphatics. They are not dilated lymphatics. Okay. The next thing that is important is when you The histological changes that you see in IBD can be seen in a variety of conditions. So therefore, the diagnosis is clinico-pathological. You can't rule out other things. And in fact, if you want to rule out other things, it has to be with clinical findings as well as a proper history. Therefore, every colonic biopsy should be accompanied by a proper requisition form which has the history, clinical and endoscopic findings. If they are not there, just call up your gastroenterologist or walk over to his office and talk to him and find out what it is. This is very important, okay? Because many of the time, based on your discussion, they may give a therapeutic trial. For example, you can't make out whether it's Crohn's or tuberculosis for sure. A trial of anti-tubercular treatment is given and that's accepted. And you review the case after say 3 months and then 6 months. So that's an accepted form. So it's very important. Now the other thing is the diagnostic accuracy increases with the number of samples. So it's known that when we are newly diagnosing an IBD, there's a rule of 2. Take 2 from terminal ileum, 2 from the cecum, 2 from ascending colon, 2 random biopsies from the transverse colon, 2 from the descending colon, 2 from sigmoid colon and 2 from the rectum. So all these, there are say about 7 sites you have to take, 5, 6 or 7 sites they take, 2, 3, 4, 7 sites. And then at follow-up, you have to take any lesional area, you have to biopsy. And you have to take 2 from the rectum, at least, in say UC and Crohn's disease. And in long-standing disease, where you suspect dysplasia and carcinoma, every 10 centimeters you have to take 2 biopsies. That's what is recommended. And of course, in addition, if there's any gross lesion, you have to take from there. See, the biopsies will include only the mucosa and submucosa portion of it. It will not include the muscularis propria and the deeper serosa. So therefore, some interpretation will be limited in many of these cases. Now look at this, right? This looks like a crypt altogether. But this is actually from the duodenum. This is the villus and the crypt. So the crypt in the colon is almost like the crypt is what is seen in the duodenum and small intestine, except that there is no villus. So one has to be very careful of all this. The biopsy should be well oriented. Very difficult to say whether KIPs are hypoplastic or atrophic or whatever with this. This should be well oriented. And generally in an adult you will get a bit of muscularis mucosae. In pediatric age group, unfortunately, this may be a luxury, right? The crypts normally rest on the muscularis mucosae, right? And for every millimeter of the mucosa, you have 7 to 8 crypts, and branching is seen in less than 10% of these. This is one thing very important. So what is the histological pattern in ulcerative colitis and Crohn's colitis, and those colitis in which you can't differentiate between ulcerative and Crohn's? It is a crypt destructive colitis. The crypt gets destroyed and it goes on over a long period of time. So it's a chronic crypt destructive colitis. So it's almost CCD colitis, cafe coffee day cell colitis. The other things that can show similar features are a whole list including drugs, diverticular disease, diversion colitis, idiopathic and so on and so forth. So we'll leave that. Now inflammation is followed by healing and repair. So that's what you see in chronic crypt colitis. So you see inflammatory cells, normally they are more in the superficial portion than in the deeper portion. But when there is inflammatory bowel disease, you get neutrophils, increased number of plasma cells, lymphocytes. Then you get a mixed plasma cellular infiltrate. By about a week's time, you will get this. And this will help you differentiate from an infective colitis when there is significant basal plasmacytosis. And it also means when there is significant basal plasmacytosis, the inflammation is likely to remain for a long time. You have to look for active inflammation, that is inflammatory infiltrates with neutrophils. So these are the basic inflammatory features you see. So the epithelial response to injury begins in the lower crypts and spreads upwards, lower portions of the crypts. And the reactive epithelial proliferation, and there is increased mononuclear inflammatory cells, can be seen in IBD, but it can also be seen in recently resolved inflammatory processes where there is mild epithelial injury, right? Branched and regeneration of crypts are a feature of chronic colitis, and they take several weeks. So you will not seen when the biopsies are taken early in the course of the disease. Paneth cells metaplasia, that's in the left side of the colon, helps to identify chronic colitis. So a lot of plasma cells, branched crypts, Paneth cell metaplasia will help you in telling this is a chronic colitis, right? And then of course, hypertrophy of muscularis mucosae, loss of epithelial attachment, which we'll see, are other features. So now let us see what are the features of chronicity. Architectural abnormalities, metaplasia, inflammation, some stromal changes. An active inflammation is neutrophilic infiltration and ulceration. There may be other features, changes in mucin content, dysplasia and neoplasia. So we'll see each one of them for making the diagnosis. So the main things are what you will find in most biopsies are architectural abnormalities and inflammatory changes, that is basal plasmacytosis. First, on the low power, see whether the inflammation is uniform or not in all the biopsies. It's very important. All the biopsies are not put into one container. I told you each part of the mucosa looks different. Therefore, it is worth putting the biopsies of the ascending colon in one container, transverse colon in one, ileum in one, descending colon in one, sigmoid colon in one, and rectum in one. You may have to make 6 or 7 blocks, but it is worth it. You examine all the mucosal fragments under low power, and supposing, see this mucosal fragment looks fairly normal, although it's not well oriented, see the inflammation. Whereas this looks more inflamed. The crypts are more and the inflammation is more. The surface epithelium doesn't look well here compared to this. So when it is patchy, it means the changes are discontinuous. Think of Crohn's disease if it is inflammatory bowel disease. If it is ulcerative colitis, the amount of inflammation here will be similar to the inflammation. Ulcerative colitis is a continuous disease. Crohn's colitis is a discontinuous disease, so you find skip lesions or segmental. That's why it's called segmental colitis. Now the architectural abnormality is a crypt distortion. They are not parallel to each other. However, well you orient, see the mucosa, this is well oriented here, straight, but they are in different directions, so you don't see them. And you're finding a lot of Paneth cell metaplasia on the left side. Okay, the mucosal surface is irregular, right? So this qualifies for architectural abnormality. And if crypt abnormalities are more than 10%, here it means 30-40% are abnormal. So it is abnormal, significant. Then crypt distortion. They are not only non-parable, they are variable diameter and often they become cystic. So these also qualify for architectural abnormality. Okay. Then crypt branching, which I told you, but beware, don't, if it is in a child or above a lymphoid follicle, then you must not take much cognizance of it. Crypt branching is an important sign. That's another thing which will tell you. More than 2 branch crypts in a biopsy with inflammation is important, because this is how the crypts are regenerating and dividing. The crypts are getting lost, the cells are damaged, so they regenerate, and this is how they divide. That's how you get branches. Okay, and when you cut it across, you may find 2 of them by the side of each other. The other thing is, this is important, you see, this is the muscularis mucosae. Normally, the crypt should be resting on this. There is a gap. So this is crypt shortening. Very important to know that. There is edema here and crypt shortening and a lot of inflammation here. Okay. Then you see, there is decrease in the number of crypts. Obviously, it's much lesser than what you see. They almost touch each other with very little gap. There's a lot of gap here. So this is crypt density, or many people say crypt is atrophic. But this is a better term, decrease crypt density. Even crypt shortening people use as atrophy. But you can say the crypts are shortened and there is decreased crypt density. This will be much better term. Then the mucosal surface becomes irregular. It's almost villus-like. This is a very important feature seen in all chronic colitis. It should be smooth like this. Here, there, villus surfaces. And then, of course, you can get ulceration and all these inflammatory cells. Right? This is another area where the crypt epithelium is lost. Then Paneth cell metaplasia and pseudopyloric metaplasia are other metaplasias. Paneth cell metaplasia is more common in the left side of the colon, which is significant. Basal plasmacytosis. Accumulation of plasma cell at the base of crypts is another important feature, right? This is very important and you have to search for them. Then this basal plasmacytosis is more often a feature of ulcerative colitis than Crohn's, although you can see in both of them. Then the other feature you will see is granulomas. Everybody agrees that if you find a granulomatous colitis, Crohn's is a differential diagnosis in a case of IBD. Okay, and this is seen in quite a few of Crohn's disease. But in our country, the problem is tuberculosis is a very close differential diagnosis. Just as tuberculosis is a differential for sarcoidosis in a pulmonary biopsy. These generally Crohn's granulomas are small in size. We'll come to all of that in detail later. Please remember, if a crypt is cut tangentially, it may look like a multinucleated cell. Be very careful about all this. If you are in doubt, you see the nucleus will be similar to the crypt nucleus. It's very easy to make out. Sometimes you get a rim of other cells all around. So that's another thing you have to see. Sometimes when mucin is extravasated, you get granulomas related to extravasation of mucin. But that's not that's not the granulomas of Crohn's. Okay, right? They are less reliable for diagnosing Crohn's disease. Okay, this is an example. If the granulomas are large, they fuse into each other, they are confluent, and they're showing necrosis and present mainly in the submucosa, then it's most likely because of tuberculosis. This is what you see in a confluent granuloma, okay, with some necrosis here, right? So this would be in tuberculosis. This is a small submucosal granuloma. Sometimes you can get in resected specimens of Crohn's disease also, okay? But this is a small necrotizing granuloma becoming confluent. Now these are the problem cases where you'll wonder what it is. Now, if the granulomas are small, then you have to think of Crohn's disease. Conventionally, most granulomas will have about 25 epithelioid cells, or they are more than 200 microns or 2 crypts side by side. You just see it on the microscope. If they are larger than this, no, okay, that will be about 200 microns. Now, if the granulomas are smaller than this, they are microgranulomas. Many people say it should be less than 1 crypt or 100 microns. So, but in general, it's 200. If it is more than 4 crypts or 400 micrometer in size, then they are large granulomas. Between 200 and 400, they are medium sized granulomas. So, microgranulomas are found typically in Crohn's disease. Large granulomas, more than 400 micrometer in size, are found typically in tuberculosis. Generally, if it's more than 200, you have to think of tuberculosis. Okay. The granulomas in Crohn's disease are microgranulomas. The histiocytes are loose aggregates, non-necrotizing, non-confluent, next to the crypt, not found in draining lymph nodes, but they can be found in about less than half the case of Crohn's. And in endoscopic biopsies, in about a quarter of the cases, but you have to take multiple step sections. In fact, my dear friend Anna Pulimut from CMC says that they have almost one tray of sections, from a single block, almost 20, 25 sections. They almost exhaust it. And that's why they find a lot more granulomas than we or any other institution finds. They do a very good job with this, especially the endoscopic biopsies for IBD. Then granulomas are more common in children, but rather than in adults. But Crohn's is more common in adults. And if you find it away from the ileocecal valve, stomach, or in the upper part of the intestine, or in the rectum, left side of the colon, it is more likely to be Crohn's than tuberculosis. And if you find near the ileocecal valve, we'll come to this, it's likely to be tuberculosis. So, but granulomas are not necessary for diagnosis. More likely when if you do more colonoscopies. In fact, do 4 colonoscopies one after another at different varying intervals, and then you collect all the slides and see them, the likelihood of finding granulomas increase. If you take at least 6 biopsies, the diagnostic frequency of finding granulomas increases. If you take serial sections, then at least with 5 or more sections, the chances of finding granulomas are more, right? So this is Crohn's disease, and you have to mention the other things I told you, focal and patchy, just to revise. And to revise that, more than 2 lymphoid follicles per millimeter of biopsy is, or 10 crypts, then they are abnormal. This is submucosal inflammation. Ulcerative colitis generally doesn't show submucosal inflammation. Crohn's shows. Crohn's goes up to the muscle, that's why you get a lot of fibrosis. Mucosa can heal, but fibrosis is seen when submucosa and deeper portions are involved. Don't get strictures in ulcerative colitis. So it's more likely to be Crohn's. See the epithelial damage and other things. Okay. So then what is an aphthous ulcer? Many people ask what is aphthous ulcer. Clinically, it is when you see a small ulcer in the endoscopy with the hyperemic zone, they call it aphthous. But histologically, to a pathologist, aphthous ulcer is an ulcer over a lymphoid follicle. So that's what is an aphthous ulcer. That's typical of Crohn's. Panicell hyperplasia, hyperplasia muscularis mucosae are other features in chronic colitis. Submucosal fibrosis is more often seen in Crohn's disease. Okay. active inflammation. When will you say? So these are all till now features of chronicity. What is active inflammation? Cryptitis, cryptapsis, inflammation in the surface epithelium, and neutrophils in the lamina propria. So it's all to do with neutrophils. Then if you get ulceration, that is active colitis, right? So anyway, so the other features you have to see is whether there is any dysplasia or neoplasia. We'll come to that later. Okay. In all inflammatory bowel disease, it's good to search for cytomegalovirus in whenever there is sudden exacerbation of these symptoms. So this is an CMV here. Search for them in the endothelial cells, right? You'll find, then generally you'll find this owl-like nucleus, or you can do a CMV stain, right? Which will help. This is very helpful. So for Crohn's disease, discontinuous crypt architectural abnormalities, mucin preservation of active sites, discontinuous inflammation, focal cryptitis, small granulomas. At least two features should be present, and you should correlate with clinical and endoscopic findings. This is a study from Vellore, which they found taking multiple biopsies. In tuberculosis, it's concentrated around here. Whereas in Crohn's disease, the findings are there, and as well as here in the left side of the colon. Okay, so this is a very important finding. It's a landmark paper by Pullimud Ramakrishna and others. So the difference between histological diagnosis of Crohn's and tuberculosis is, in tuberculosis, more likely you'll find granulomas than in Crohn's. Caseation, more likely tuberculosis. AFB positivity you can get in about 5%. If you do molecular studies, you can the yield of acid fast bacilli will be about, means finding of Mycobacterium tuberculosis by PCR of the sample will be about 20% or so. So those are the other things. You can do it with quantiferon gold report, whether it's positive or not. Actually, if it is, if it is positive, then it is unlikely to be Crohn's. So it has a strong predictive value as far as Crohn's is concerned in that way. Confluent granulomas, tuberculosis, large granulomas, many granulomas, submucosal granulomas, whereas in Crohn's you'll get a lot of mucosal granulomas which are small and isolated. Granulomas in lymph node, you get it in tuberculosis. Very rare in Crohn's. And of course, rectal granulomas are more common in Crohn's. Ileocecal granulomas more common in tuberculosis. Right? So, or it's the other way around, you can say, in Crohn's, ileocecal granulomas are relatively rare. What are the unusual features of IBD? Because of treatment, many features may not see, especially in remission. Sometimes the appendix may be involved. Sometimes the cecum, usually in ulcerative colitis, starts in rectum and goes there. Sometimes the left side may be spared in ulcerative colitis. In pediatric cases, in fact, the rectum is invariably spared and you get skip lesions just like in Crohn's disease. So that is one unusual feature. You can get backwash ileitis. Rarely, in about 5 to 10, sometimes up to 15%, you can get upper GI involvement, meaning the stomach, duodenum, esophagus may be involved, and fulminant colitis. Sometimes you'll see there are overlapping features of ulcerative colitis and Crohn's disease. Granulomas may be absent. Then how do you differentiate between the two? Sometimes you cannot differentiate. On endoscopic biopsies is difficult, and sometimes you have to do a resection, and in the resection specimen also when you cannot do, then you can safely classify as IBD unclassified, right? 20% of these as the number of unclassified can be very high in some institutions and low in others. You have to take multiple sections and see that. And the common reasons for calling it indeterminate colitis is fulminant colitis, where there are fissures, transmural inflammation, or rectal sparing in ulcerative colitis. When there is insufficient background material for you, when you are basing your interpretation solely on mucosal biopsy, and failure to recognize the unusual variants. Okay, so and if there is secondary disease like pseudomembranous colitis, ischemic colitis, then also you can say that there is this. But when you actually see most of the indeterminate colitis, 8 to 10% will turn out to be ulcerative colitis, but 30 to 40% will turn out to be Crohn's disease. So in about half of them, ultimately you can make a diagnosis by clinical follow-up. This is an severe acute colitis or fulminant colitis. Very difficult to say it's ulcerative colitis because the inflammation is almost transmural in this case with necrosis. So it becomes very difficult to make a diagnosis of ulcerative colitis unless you have prior history and other findings. So this is one of the features, right? This is divergent colitis in which it's difficult to make out. Divergent colitis is they make the transverse colon is put to the exterior or ascending colon, and the remaining portion of the colon is left there to be removed later, like in Hirschsprung's disease and all. So they have a colostomy bag. Colon that remains unconnected to the main gut, the flora changes and other things changes. They don't absorb the nutrients and other things. They show a lot of lymphoid hyperplasia. So this is divergent colitis. Next is you have to identify dysplasia because almost 2% of colorectal cancers are because of IBD. The risk of ulcerative cancer in ulcerative colitis increases beyond 30 years. Beyond every 10 years, there may be 2%, then 8%, and 18% in 30 years. In Crohn's disease, it is less. It's almost half of what you see in ulcerative colitis. Nevertheless, risk is there. In India, it's about 3% in 20 years, slightly less than what is seen in the West. Okay, so the overall risk at 22 years in studies, in some studies, show that in ulcerative colitis and Crohn's disease, it may be similar. But anyway, the duration of colitis, early age of onset, more colonic involvement and severity of inflammation, along with family history of colorectal carcinoma and primary sclerosing cholangitis, increases the risk of dysplasia and cancer in inflammatory bowel disease. So how will you detect dysplasia? You must do frequent colonoscopy and take a number of biopsies. Generally, because after 10 years the risk increases, from 8 to 10 years, when there is pan colitis or the entire colon is involved, people start doing surveillance biopsies. And if there is only left-sided disease in ulcerative colitis especially, from 15 to 20 years, you have to do surveillance biopsies. So you obtain 2 to 4 random colon biopsies every 10 centimeters with additional samples of any suspicious areas. Okay. So what are the types of dysplasia? Is it flat, not raised more than 2 millimeters, or is it raised more than 2 millimeters? Then is it endoscopically non-resectable? They are called dysplasia associated lesion or mass, or it is endoscopically resectable like a polyp or an adenoma. Then you have to say. So these are non-polypoid ones. and these are the polypoid ones, pedunculated, sessile. Okay, so you have these different endoscopic features which are there, and they do nowadays they inject dyes also. They do chromoendoscopy and try to find out the abnormal areas. So what are the things when you see a dysplasia? You have to write in your report negative for dysplasia when the epithelium is normal or regenerative. It is associated with cryptitis, cryptabscess, ulceration. Stay away from diagnosing dysplasia. If the surface epithelium is mature, then it is unlikely to be dysplasia. It's most likely what you see changes in the lower portion are regenerative. Then you have indefinite for dysplasia. What is indefinite for dysplasia? Sorry, will be here. This is the normal colon. Okay. Here there is a lot of inflammation, cryptitis. We have to stay away from calling this as dysplasia. Okay. So this will be negative for dysplasia, and this one will be indefinite for dysplasia, although there's hypochromasia and other things. Note here, cryptabscess, the epithelium is matured, there's a lot of inflammation. So in these cases, indefinite for dysplasia. The other thing is, if this dysplasia changes are focal, restricted to crypt basis, if there is inflammation and ulceration, and it depends on the confidence the pathologist has, take a second opinion whenever you hear this, right? So this is another example. Here, it's only patchy dysplasia here in the lower part. This area, it is not there, you see? So you're not sure, call it indefinite for dysplasia. Low grade dysplasia, there is no surface maturation. First, the glands are crowded. They are similar to what you see in tubular adenomas. Mucin depletion is there, and the nuclei are large and cigar shaped with hyperchromatic nuclei. Mitotic figures may be prominent. Atypical mitosis are not seen. This will be low grade dysplasia. No mucin. Here, cigar shaped nuclei. Here, some variation, right? And if you see in the surface of this also, you'll see similar changes. Surface of epithelium. High grade is much more. High nuclear cytoplasmic ratio, mitosis, crypt branching, back to back growth, and so on and so forth. So it's very easy to make out that this is high grade, and the same changes are seen on the surface also. It is very important that you identify these different types of dysplasias. Because if you write indefinite, they'll do colonoscopy in 3 to 6 months. Low grade, depending on whether they're resected or not, they may do it. If they cannot remove and there's still dysplasia, they'll do a colectomy. That's a big decision. High grade dysplasia, whether it is polypoid or flat, they'll have to do a colectomy. So you see this, if you write dysplasia in a report, it has a very sinister connotation. Take a second opinion and then make this diagnosis. Now there is no gold standard for diagnosis. Clinical feature, endoscopy, imaging and histopathology are important. So when you are reporting an IBD, you don't have to write big things. There are certain things you have to just write. Mucosal architecture, lamina propria, neutrophil infiltration and epithelial abnormality. Very important things. Okay. Is the mucosa inflamed? No. If it is yes, is there any feature of IBD? Then it is not, there no feature is not IBD. You may favor IBD. It is very likely IBD. See if it is ulcerative colitis, definite or very likely. Ulcerative colitis favored over Crohn's, or you cannot make a diagnosis. Or Crohn's is favored over ulcerative, or Crohn's definite or very likely in the endoscope. These are the 5 categories you have to give in your report. So why do you have to give this? You have to confirm the diagnosis which is made clinically and endoscopically, Try to distinguish between ulcerative colitis and Crohn's disease, exclude dysplasia, and see for activity of the disease. Okay? And most of the biopsies will have a endoscopic and clinical findings. So it's very important. Okay? And insist on all the biopsies being sent to you properly. Okay? And the earliest changes will be basal plasma cytosis, and you get the other changes as the time pass. There are a lot of mimics. I have shown some of them. You need not worry about all of them now. Now there are various schemes of reporting. Some are very complicated, you know. This is the activity index. You have to give different numbers for different things. But there is even very simple one, that is the Nancy histological index. Ulceration, yes, it is grade 4. If there is no ulceration, if there are acute inflammatory cells, yes, moderate to severe, grade 3, mild, it is grade 2. If there is only inflammation, moderate to severe, grade 1. If there is no inflammation or very little, it is grade 0. In a setting of IBD, this histological index is very simple. All of you can practice. The other thing is, for reporting, if there is a mnemonic, PAID, PAID, pattern, activity, interpretation, dysplasia. This was given by the British Society of Gastroenterology as a reporting guideline in 2013. Many people follow it. You can follow it. Very simple. So what you have to do is pattern. See the sites involved by the disease. You have different biopsies from different regions. What all are involved? Anatomical distribution. Is this continuous? All are involved. Segmental, some are involved, or a single site is involved. That's the second thing. And third is intrasite. Is it diffuse, patchy, focal, or combination, which I told you beforehand. Activity. If there are no neutrophil, erosion or ulcers, cryptitis up to 25% of crypt abscess 10% or both. Moderate more than 25, crypt abscess more than 10. In severe ulceration, right? So this is, you have to say the degree of activity. Sites involved, again, which all biopsies are showing, and you have to tell the sites of maximal activity. Dysplasia, no dysplasia, low grade, high grade, indefinite, and which all sites are involved, right? So for example, in initial biopsy, pattern, diffuse chronic colitis involving sigmoid colon rectum. 2 biopsies were given to them, sigmoid colon and rectum. Mild activity in the rectum. Inflammatory bowel disease, because rectum is involved more than the colon, strongly favoring ulcerative colitis over Crohn's disease. Okay? No dysplasia. Okay? Or therefore they make the histological code is A1. Inflammatory bowel disease, definite or very likely. Ulcerative colitis, definite or very likely. Finish. Dysplasia is 0. Whatever language you write, this will convey a lot to the clinician. Another case, patchy chronic colitis, cecum to transverse colon with minimal rectal inflammation. The moment it is patchy, unlikely to be ulcerative colitis. Severe activity in cecum, ascending colon, mild activity elsewhere. Features strongly suggestive of IBD. Crohn's disease is favored over UC. It is not definitely Crohn's disease. You can't say definite. They have not written about granulomas. No, you have not found. So it favors Crohn's disease because it's patchy over UC. No dysplasia, but it's not definite. IBD, definite or very likely. Crohn's disease is favored, no dysplasia. Now in follow-up, say 10 years, chronic colitis involving sigmoid and rectum, it must be ulcerative. Mild activity, sigmoid rectum. Histological features of IBD strongly favor UC over CD, no dysplasia. So same thing, patchy chronic colitis involving the same similar thing, low grade dysplasia and rectum. So this should report like this will convey a lot more to the clinician, whatever may be your long diagnosis. So if the endoscopy histology matches, they are typical, they give specific treatment. If the endoscopy is typical, histology is suggestive, they may still give specific treatment. If endoscopy is typical, histology is not typical, they may follow up. If either one is, both of them are only suggestive, they may follow up, no changes, other causes. For example, it is now you don't know whether it's Crohn's or TB, they will give therapy, anti-tubercular treatment. In about 2 months' time, almost 70% will show a response. By about 6 months' time, almost 100% will show a response if it is TB. But even then, they do a biopsy because some cases of Crohn's may be associated with some TBs or something. So that's why they do a biopsy at the end of 6 months to see if the mucosal changes are there or not. This is acceptable, where treatment will almost define the diagnosis. The small thing you must know, many times for ulcerative colitis, they do an ileal pouch and anal anastomosis. They remove the colon and the ileum is connected to the anal. Because the colon has to be removed, colectomy, there's dysplasia, severe disease or whatever. So the ileum is connected. What happens is the ileum becomes like a colon after some time because fecal material and other things are there, and it develops ulcerative colitis in about sometimes starting from 1 year to after 10 years. If there is concomitant PSC, this inflammation or this ulcerative colitis like illness in the colonic pouch, which is made of the ileum, begins to start much earlier. So you see, it is much more if there is PSC. So this is called pouchitis. So you can get pouchitis. They do a biopsy and you are supposed to look at the histology and see if there is activity, polymorphonuclear, none, mild, moderate, severe, ulceration per low power field, none, less than 25%, 25 to 50 or more than 50, and you give a score. So this is a pouchitis score. So you give a pouchitis activity index depending on all these features, and with this activity index they will decide what treatment to give for this pouch. So there are a lot of features which can predict pouchitis. If they are primary sclerosing cholangitis, extraintestinal manifestation, postoperative thrombocytosis, and genetic factors, and so on and so forth. So it will be acute pouchitis is less than 4 weeks, chronic after 4 weeks. They may be relapsing and so on and so forth. There are various classifications. So to summarize, interpretation of colonic biopsy relies on principles of interpretation of biopsies like in other sites. Thorough knowledge of the normal is very necessary. All fragments and sections must be evaluated to detect focal lesions. Take multiple sections, don't be miserly. Endoscopic biopsies must be labeled separately. You are not doing anybody a favor by putting all of them in one. You may be saving money, but you'll also waste a lot of money on diagnosis. Broad histological patterns, and you must do a clinico-pathological correlation. Thank you very much. This is the institution where I go to now. And this is where I learned everything from my teachers, my colleagues, students. Thank you so much.
Thank you, sir. Thank you for your elaborative and quite lucid presentation. Now we'll take up some questions. One question from Dr. Shubham. The question is, when the histological features are overlapping, we give a indeterminate colitis. So what the clinician should do next? Should he wait for any biopsies after some time, or he should initiate the treatment?
See, many times,
Yes, sir.
where the indeterminate colitis is between ulcerative colitis and Crohn's disease.
Yes.
The other thing is between Crohn's disease and tuberculosis. See, if it is between ulcerative colitis and Crohn's disease, they often start treatment like ulcerative colitis. They give mesacholamine and sulfasalazine, the usual standard treatment, and they see and they follow up. It's very unlikely they will not give any treatment because endoscopically and clinically, usually the gastroenterologists are fairly sure that this is IBD. They will give course of this usual treatment and then they see how the patient does after responds after that. Generally, what people say is that supposing even then they are not sure and the disease becomes severe, they feel it is most likely Crohn's. Sometimes they resect the specimen and they give you. The problem is there. There they expect that you give a proper diagnosis, whether it's ulcerative, whether it is Crohn's. There also, even then, some small proportion you will not be able to tell whether it is Crohn's or then also you may give indeterminate or IBD unclassified. Then also they follow up, then they usually treat like Crohn's. And then they see whether the patient is improving or not. Then they do that. Like ulcerative colitis, they may give even steroid enemas and all that and see it. It is true in some cases, but fortunately, those are small number of cases.
Yes. So one more question, like what system of reporting do you follow, that British system? Do you incorporate in a day-to-day reporting routinely?
Yeah, you see, in a day-to-day reporting, it is almost like that. What you have to tell is whether it is IBD or not.
Yes.
Right, I'll see this one, these changes are there. That is one. Second, is it ulcerative colitis or Crohn's disease? That is the second point you must. Third, if it is when it is IBD, you have to give a activity index. If there is lot of cryptitis, cryptapsis, then they may give more aggressive treatment, steroids and other things. And the fourth thing is whether there is dysplasia or not, especially if it is diagnosed after long standing, more than 10 years. In that, more than if it is 8-10 years, if you don't write about dysplasia, it is not good. If a 1-year-old, just recently diagnosed, you forget also, even the clinician doesn't expect. It's better to give all the points. So first, IBD or not, ulcerative colitis or Crohn's disease, whatever, are likely or you favor one over the other. Activity, and the fourth thing is dysplasia or not.
One more question from Dr. Barney. So he's asking, in which condition dysplasia or malignancy is more common, whether it's ulcerative colitis or a Crohn's disease?
See, it is more common in ulcerative colitis, especially if they have PSC. But there are some studies which show, they say Crohn's is a little less, about almost half, but some 2 or 3 studies say no, in their patients, it is almost identical. At the end of about 20 years or 30 years, if you take at 10 years, 20 years, 30 years, generally as in 10 years it may be 2-3%, but at the end of 30 years, it will be about 18-20% for ulcerative colitis. People say if it is Crohn's, at the end of 30 years, it may be 10%. Some others say no, it is almost equal in both. Okay. So, but in general, the feeling is ulcerative colitis, especially PSC and all, those patients higher chance of malignancy. Patients in there's a family history of colorectal carcinoma, higher chance of malignancy. Patients who have not taken any treatment, there's continuous inflammation for a longer period of time, higher chances of inflammation, higher chances of malignancy. So these are the.
All right, sir. We don't have any more questions. So I thank you on, sir. I thank you on behalf of KCIAPM for this wonderful webinar. Now I will hand over the session to Dr. Aditya for giving the brief view of the upcoming AppCon website. Thank you, sir. I'll hand over to Dr. Aditya.
Thank you, Datta Gupta sir, for such a lucid and comprehensive presentation. I'm sure all our delegates who joined us today learned a lot. Now, before we end this webinar session, I'll briefly showcase, as you all know, the 70th National Conference of IAPM and IPID will be organized in Bengaluru, this year on November 30th to December 4th. It's a 5-day event. On 30th November, we'll have 17 different workshops spread across Bengaluru. And on December 1st, there will be IPID conference. And December 2 to 4, there will be AppCon event. So our website is ready for registrations, and we will begin the registrations tomorrow. I'll just briefly showcase it for you all now so that you can have a fair look at it. So this is the AppCon 2022 website, as you can see on the screen. This goes live on www.appcon2022.com, and these are the dates of the conference: November 30 to December 4. And the conference venue will be MS Ramaiah Medical College, Bengaluru. And you'll be able to access why attend the conference, about the conference. We have all the key highlights, and there'll be 10 plus competitions during this, which you can participate. And the registrations for all of these sub competitions will start from 15th of June. These are the important dates. Early bird registrations will be from 11th June to 15th July, and abstract submission pay for all the competitions will begin from 15th June, and the last date will be 15th August. And we are hosting 17 different pre-conference CMEs and workshops, which you will be able to register. The conference is in a hybrid format, so you'll be able to register for these workshops only if you have a physical registration. But we also, and for those who cannot come down to Bangalore for whatever reason, you'll be able to join us still virtually. Okay. There's no provision for online paper or poster presentations, and registration for a physical event is necessary for workshops, paper, poster, and quiz competitions. So when you go on, here's this amazing scientific program. We are still coming out with it, and these are all the workshops that we are hosting, and we'll be adding more in days to come. And here you'll be able to scroll down to the entire scientific program by clicking on the respective dates. And you will also be able to download or print the agenda from your phones. Okay, and here is the registration section, and here you can go through the website. We have the early bird registrations going on till 15th of July, and they are mandatory. Since it's a hybrid conference, the KMC, the Karnataka Medical Council credit hours given will also be different for both the physical and the virtual delegates. But virtual delegates will miss out on some of the amazing one-to-one breakfast sessions. Will be informal breakfast sessions that we are planning this year with experts, and they'll also not be able to present paper, poster, or participate in Path Innovate competition, which is being organized for the first time ever. And they'll also miss out on the banquet. But the certificates, as I said, will be different for physical and virtual delegates with the different credit hours. Okay, and here are all the registration tickets that we have for PG students, IIPM members, non-IIPM members, international delegates. All of this will go live tomorrow at 12 a.m. tonight, and you'll be able to pick any of them. So once you have registered, so only the physical delegates will be able to register subsequently for the workshops. So once you register for the workshop, the website will look something like this. Okay, you'll be able to log into your sessions. You'll be able to create your own profiles here, and like this, and fill out all the details. And you will also be able to download your whatever tickets that you register. This will be basically your ID card for the conference. Okay, and you'll be able to download your ID cards here, and your registration tickets will appear in this ticket section. And after that, in the registration counter and the scientific program, if you're interested in a particular session, you will be able to save those particular sessions that you want to attend. Say I want to attend the guest lecture by foreign faculty, and on day 4 I want to attend this Dr. Gaya Prasad Memorial Symposium. You will be able to save all of them and build your own scientific agenda that you want to attend. And only after you've registered for the conference, for the physical event, you will be able to, all these registrations registrations for the workshops will get activated. So each delegate will be able to register for only one workshops, as all the 17 workshops are happening simultaneously across Bangalore, and it will be for an entire day. So you'll be able to register for only one. So once you've registered for the event, then you will go to the workshop section and register whatever workshop that you're interested in, and each registration is 1,500 rupees. Okay. So that's about it. So, and we'll also be launching a custom mobile app application for AppCon 2022 in another couple of weeks. So meanwhile, you can get started with registrations, and the registration links are live, and we will also shared it in the WhatsApp chat groups. Okay, please do register. Please come to Bangalore, and we will be and join us for the extravaganza that we have planned here today, this week. Sorry. Before I let you go, I'll share the video of the promo video that we have prepared for AppCon. All right, dear friends, I think the Garden City and the Silicon Capital of India, Silicon Valley of India, is looking forward to hosting you all at AppCon 2022. Please do join us, and please register for the conference. And before I end, I would like to thank Dr. Professor Siddharta Datta Gupta sir for such a wonderful presentation. And I'm sure all our delegates will go back and watch the session again, because there was so much information loaded in it. Thank you, Gupta sir, for such a presentation. Thank you all for joining us today. With that, we'll be closing the session. Thank you.